Hi everybody and welcome to lesson 4. What we're going to be looking at, this is only a short video by the way, we're going to be looking at a quick overview of the assessment and then the management of CKD. The reason why I'm keeping it short is because I'd rather spend time on the actual patient assessment, which is what we're going to be doing in the last video. So this is just an overview. We will be expanding on all of this in the next video. Okay, so with regards to the assessment, one of the big things about CKD is, and CKD annual reviews, a lot of it is to do with assessing for any risk factors that may accelerate the progression of the disease. So a big part of your annual review, the content of it, if you like, is to be looking for anything that might accelerate that loss of that EGFR. So what's going to, if you think about your EGFR and if it's sitting there at 60, is there anything going on inside that body that might make it actually drop to 45 within 12 months? So that's what this really is all about. And when we talk about risk factors, there's the kind of, in a way, I think the usual suspects really. The biggie in CKD is hypertension. Because if you can imagine inside that little glomerulus and all of that pressure, and the more pressure that there is within those tiny little blood vessels, the more likely they are to pop and cause more damage. Lots of lipid doesn't help floating around any blood vessel. It especially doesn't help the tiny little vessels of the kidney. The chemicals in cigarette are highly toxic to every part of our body, but they are especially toxic to kidney vessels. A few years ago, I was running a course in North Wales. It was a diabetes course, and we'd invited some renal specialist nurses onto the course. So, because even though they were specialists in kidney disease, they didn't really know that much about type 2 diabetes, you see. So they wanted to come and learn about diabetes as a disease. But it was absolutely fascinating listening to their take on kidney disease. And one of the nurses asked them, they said, right, if you were doing an annual review, what is the first thing that you would focus on? All of them in an instant and in a flash said cigarette smoking. And I was so shocked at that because I was convinced that they'd zoom in on hypertension, but they didn't. They progressed to tell us as to how toxic the chemicals in cigarette really is to the tiny vessels within the kidney. So it's just something to kind of be aware of, is that if you've got yourself a diabetic, the worse the glycemic control, the bigger the impact it has on kidney function. And then, of course, we've got dietary and lifestyle factors. We will be picking up on all of these when we do the assessment in a short while. So what is it that we should be focusing on in our annual CKD review? Well, it's the usual suspects that we've chatted about now throughout this course. So I don't need to tell you much about any of these anymore. But obviously these are essential. If you've not got all three of these, you're going to struggle to do a decent annual review. Things to look out for: accelerated loss of that EGFR. Now, nice guidance defined that if you've got an EGFR that's dropped by more than 25% from its baseline, so let's say it started off at 100 and it's now dropped to 72 mils per minute, and that has caused for them to have a change in the category, so they've gone from a G2 to a G3 within 12 months, that's called an accelerated decline. And if you identify patients in the annual review with an accelerated decline, these are the ones that you may need to think about asking for referral to a nephrologist or a renal doctor. Another one as well is if you start to get a sustained decrease in the EGFR of 15 mils within 12 months. So again, this means you need to look at what is the EGFR today? What was it last year? Has it dropped more than 15 mils? And if it has, this is something that you would have to report on to the clinician within your practice, the clinician who has got the ability to be able to consider whether or not these people need referral. Just one thing to remember though, small fluctuations in EGFR are common, and it doesn't necessarily mean that the disease is progressing. It might mean that, but it might not. But just to be aware that it is common, and because of that, in order to assess the rate of progression, if you start suspecting an accelerated loss, you might want to think about checking the EGFR more than once. The guidelines recommend 3 times over at least 3 months. So that might be what your clinician says. They might say to you, brilliant, wonderful that you've spotted that. What I'd like you to do now is I'd like to check that EGFR over the next 3 months. Other thing to be aware of is we did chat in the last video about one of the functions of the kidney was to produce erythropoietin. Well, on that end, we've also got to be aware that some CKD patients may actually develop anemia. So what the guidelines tell us to do is if you've got a patient who's got a category 3B, 4 or 5, or if you've got someone with CKD 1 or 2 and they develop any symptoms that might indicate anemia, we should have a think about doing a full blood count. If it does wind up that your patient has got anemia, we've got to be sure that there isn't something else that's causing it, such as iron deficiency. However, if at the end of the day renal anemia is suspected, these people need referring to nephrologists. So just to double up on that, you don't have to do full blood counts on everyone. Definitely people who've got a G3B, 4 or 5, or patients who's G1 or 2 who start showing symptoms of anemia. So just something for you to keep your eye on at the annual review. If your patient has got type 2 diabetes, if they've got hypertension, it's okay us doing all this fancy stuff, but if we leave an HbA1c greater than what it should be, if we don't treat a blood pressure to target, this will also add further damage onto the kidney. So we've got to have a think about other aspects within the annual review that might worsen the progression of this disease. And last but not least on this particular assessment bit, I did touch on this in the previous video, but just to be aware that at the end of that annual review, your job is to decide, when do I need to see this patient again? And, you know, occasionally, sometimes what happens is patients just get put on annual QOF reviews. And you know what, that might be absolutely perfect for the vast majority of your patients, but it might not be right for that person sat in front of you. So before you put this person on an annual review, just follow the little chart to be sure that you're making the right decision for that patient. Okay, we're going to expand on this because we're going to be doing a patient assessment in a short while. Before we do, I just want to give you a very quick overview of the management of CKD. So as I said, this is just an overview, by the way, just to kind of highlight a few points that we need to have a think about. These are the main aspects of management that we need to attend to. If your patient's got high blood pressure, it needs sorting. If they've got protein in the urine, we need to start to find out why. And sometimes these people need referrals to nephrologists for the management. You know, it becomes possibly more complicated for us in general practice. We still need to know the CVD risk because we might need to manage some of these factors. I've mentioned hyperglycemia, and we will go into more detail about lifestyle when we do the patient assessment in a short while. So I'm just going to give you a very brief overview now of the management of CKD. A lot of the management actually is not necessarily focused just on the kidney. It's to do with all the factors that contribute to it, and the biggie being obviously blood pressure. So what the guidelines tell us is, if we think about setting a target for a blood pressure, the target really depends upon how bad the CKD is, if you like. So what the guidelines tell us, if your patient's got an ACR that's less than 70, we should be going for a blood pressure of less than 140/90. Obviously, the higher the ACR, the worse the damage on the inside. So therefore, we need to set a lower target of 130/80. The other thing that the guidelines say, if they've got an ACR that's actually less than 30, they signpost us to the NICE guidance on hypertension in adults. and that is you can find this. I think I've put a link on that if you can click on it, it'll take you to that on the NICE website. Just to do a real quick summary, if we've got a situation where we have got a patient with CKD and blood pressure, the recommended class of drug is ARBs or ACE inhibitors. And the guidelines recommend that we titrate this to the highest licensed dose that that person can tolerate. The reason that we use this class of drug is these drugs are actually protective to the kidney. So you know when a couple of videos ago I showed you about the dilated afferent arteriole and the constricted efferent one. Well, these classes of drug target, I think they'll relax the constricted efferent one, and in doing so they release the pressure within the kidney. It's a little bit like a pressure cooker, you know, taking the valve away and all the pressure is released. So that's why they recommend that class of drug over any of the others. It's because of how they help protect the kidney as well as drop blood pressures. With regards to statins, the guidelines recommend that we follow NICE guidance cardiovascular disease risk assessment, and we've covered that in a previous video. And with regards to aspirin, again, they signpost us to the secondary prevention of cardiovascular disease as well. If we've got an adult with type 2 and they're on an ARB or an ACE, and that has been titrated to the maximum tolerated dose, but our patient has also got type 2 diabetes, then they recommend adding in this particular class of drug. And the reason for this is that this class of drug, very much like ACEs and ARBs, they are also kidney protective. With the ACE inhibitors and the ARBs, how they relax the constricted efferent arteriole. Well, this class of drug does that as well, but it also helps to tighten up the dilated afferent one. So that's why they recommend the addition of an SGLT2. In diabetes, this isn't so much about reducing blood glucose levels. This class of drug, it's relatively new on the market. It was developed as being an anti-diabetic drug, but what they discovered, improving that it was safe to use, and it wasn't going to cause any damage to the heart, etc. They ended up discovering that not only could it drop blood sugar levels, but it was also protective of the heart, it was protective of the kidney, it can reduce blood pressure. It became almost like the wonder drug it has, and it's been elevated certainly in the diabetes guidelines, but interestingly it's now got licenses to be used in people that have not got diabetes because it is so good at protecting the heart and the kidney. So that's why they recommend adding in that particular class of drug. That's the kind of pharmacological management. Obviously there's much more to it than just this, and we need to kind of look at other aspects. We'll be touching on this in our patient assessment, which is the next video, in which we'll pull together all of this learning that we've done. Well, I hope it will anyway. So I'm going to see you in the next video, and what we're going to do is it's exactly the same that we've done in the other modules. We've got a patient, and I'm going to take you through an annual review, if you like. So I'll see you in that next video.